Welcome to the deep dive. For you, our advanced practitioner listeners, well, you know a big slice of primary care is managing those age-related health issues in men. So today we're really focusing in on the pharmacotherapy for prostatic disorders and erectile dysfunction. Our mission, it's pretty straightforward but really important. We're not just rattling off drug names. We are digging into the why behind treatments for prostatitis, benign prostatic hyperplasia BPH, and erectile dysfunction, ED. We need to get why certain drugs are picked, how they might interact, and honestly, what pitfalls to watch out for when you're talking to patients.
That's exactly right. I mean, as men get older, these conditions become, well, pretty common. BPH, you rarely see that before 40, and prostate cancer usually kicks in after 50. What ties prostatitis and BPH together often are those lower urinary tract symptoms, LUTS.
Right.
But the treatment approaches,
Right.
totally different. For one, we're trying to kill an infection. For another, we're dealing with obstruction and physical growth. And for ED, it's all about vascular response. So yeah, three conditions, three very different pharmacologic game plans.
Okay, let's dive into part one then. Prostatitis, this is the inflammation one. Our sources mention the NIH classification system. Category 1 is acute bacterial, sure, but it seems most cases are actually category 3, chronic pelvic pain syndrome, often not even bacterial.
That's correct. The majority aren't bacterial. But when it is bacterial, we're usually up against gram-negative bugs, things like E. coli and Pseudomonas. And before you even think about prescribing, getting the diagnosis right is key. That means using the 4-serial urine sample method.
Ah, that technique. Why specifically the third and fourth samples?
Because those are collected after prostatic massage. That massage pushes prostatic fluid out, so those last two samples get a much higher concentration of anything actually in the prostate.
Yeah.
It's really the only way to get a truly accurate culture from the gland itself.
Makes sense for getting the right bug. But the treatment length?
Wow.
You mentioned 4 to 6 weeks minimum, maybe even up to 12 for chronic cases. Why the marathon therapy?
It comes down to pharmacology, really. Poor tissue penetration. The prostate is just, well, notoriously tough for antibiotics to get into effectively and stay there at high enough levels.
So you need that sustained pressure over weeks.
Exactly. You have to keep those drug levels up for a long time to make sure you wipe out the organism deep in the tissue, and importantly, to prevent it from just coming right back.
Okay.
Which leads us to the first-line choices. They have to be drugs known for good prostate penetration. That usually means the fluoroquinolones, ciprofloxacin, levofloxacin. They generally offer the best tissue levels and cover those key gram-negative bacteria.
Okay. What about TMP SMZ?
TMP-SMZ or trimethoprim sulfamethoxazole, yeah, it's an option. But only if local resistance patterns look good. You have to know your local antibiogram. Remember, it's bacteriostatic, it stops growth, and works best as that combo, acting as an antimetabolite. But resistance can definitely be an issue.
Right. And sticking with fluoroquinolones for a second, these have some major counseling points, don't they? Things practitioners absolutely need to cover, potential liabilities even.
Oh, absolutely. Critical stuff. First, absorption. Fluoroquinolones chelate, meaning they bind to certain ions. So you have to tell your patients, take these at least 2 hours before or 4 hours after dairy products or antacids with aluminum or magnesium or even iron and zinc supplements if they take them together. Absorption tanks.
Okay, separate the dosing. Got it. What else?
Drug interactions. Fluoroquinolones can mess with the metabolism of other drugs. Specifically, they can raise the levels of theophylline and warfarin.
Ooh, that's significant.
Very. So if your patient is on either of those, you need to anticipate this, monitor closely, and likely adjust the theophylline or warfarin dose downwards to avoid toxicity.
And if fluoroquinolones are out, maybe due to resistance or an allergy, what are the second-line options?
Then you might look at doxycycline, that's a tetracycline, inhibits protein synthesis, or maybe macrolides like azithromycin or clarithromycin, which go after RNA-dependent protein synthesis.
All right, let's shift gears. We've covered infection. Now let's talk structure. Moving on to BPH. Statistically, this is the big one for men over 50, right? The most common prostate problem. Here, the issue isn't infection, it's blockage. So what's the underlying pathophysiology we're targeting with drugs?
Yeah, we're basically hitting two different things that cause the blockage. First, there's the static component. This is just the physical enlargement of the gland. It's hyperplasia, more normal cells growing in what's called the transition zone, squeezing the urethra. It seems related to aging, maybe changes in hormones like more estrogen relative to testosterone, and definitely the buildup of dihydrotestosterone, DHT.
Okay, so physical growth. What's the second part?
That's the dynamic component. This is about muscle tone. The smooth muscle in the prostate itself, and, importantly, in the bladder neck, is packed with alpha-adrenergic receptors. When these receptors get stimulated, the muscle tightens up. This clamps down on the urethra, increasing resistance to flow. And that dynamic tightening, that often causes those really bothersome urgent symptoms.
Gotcha. So clinically, how do we assess this? Diagnosis usually starts with those bothersome symptoms, and then we use the AUA symptom index.
Exactly. The American Urological Association Symptom Index, or AUASI, it scores severity from 0 to 35, mild is of 7, moderate is 8-19, and severe is 20-35.
And anything over 7 pushes us towards treatment.
Generally, yes. Scores over 7 suggest moderate to severe symptoms where pharmacotherapy is usually considered. We also look at post-void residual urine volume. If it's consistently over, say, 100 millimol, that's also a sign things aren't emptying well. And based on all that, we generally land on one of 3 main drug classes for BPH: the alpha-adrenergic blockers, the 5-alpha reductase inhibitors, or 5-ARIs, and one of the PDE5 inhibitors, tadalafil, which actually has an indication for BPH too.
Okay, let's unpack those classes. Starting with the alpha-adrenergic blockers, drugs like doxazosine, tamsulosin, selodocin, they target that dynamic muscle tone component, so they work pretty fast, right?
Precisely. That's their main advantage. They relax the smooth muscle in the prostate and bladder neck, easing that squeeze on the urethra. Patients often feel better relatively quickly, sometimes within a couple of weeks.
But they started life as blood pressure meds, didn't they? So side effects are a concern.
That's the main trade-off. Because they block alpha receptors, they can cause vasodilation. So you have to watch out for potential hypotension, especially orthostatic hypotension, dizziness when standing up. Fatigue and maybe some fluid retention can happen too.
How do we manage that?
Well, one strategy is using the more selective alpha blockers like tamsulosin or selodocin, which target the alpha-1A receptors found mainly in the prostate, potentially causing less systemic blood pressure drop. Also, standard advice: start with a low dose, titrate up slowly, have the patient take it at bedtime to minimize dizziness during the day, and always counsel them to rise slowly from sitting or lying down.
Okay, so alpha blockers give quick relief by relaxing muscle. Why then would we use the 5-alpha reductase inhibitors like finasteride and dutasteride? These take months to work, don't they? What's their role?
Their role is tackling the static component, the actual size of the prostate. They are most effective in men who have significantly enlarged glands, usually we think more than 30 grams or so. They work by blocking the enzyme, 5-alpha reductase, which converts testosterone into DHT, that potent driver of prostate growth. By blocking DHT production, they can actually shrink the prostate volume, maybe by 20% to 40% over time.
So they address the root size problem, but patience is needed.
Definitely. You have to tell patients it will take several months, maybe 6 months or more, to see the maximum benefit on symptoms.
Now, wait, there's a huge monitoring point here with 5-ARIs, isn't there? Something critical about PSA levels for cancer screening.
Yes, absolutely crucial. This is a major clinical pearl and, frankly, a potential pitfall if missed. 5-ARIs artificially lower PSA levels. After about 6 months of therapy, the PSA level will be roughly 50% lower than it would be otherwise.
So if you're screening for prostate cancer,
You must mentally, or actually, double the measured PSA value. That doubled number is what you compare to the age-adjusted normal range. If you forget to double it, you can miss a rising PSA that might indicate cancer. Huge deal.
definitely a huge deal.
Okay.
And adverse effects for 5-ARIs, they sound like they'd be hormonal.
They are. Since you're messing with testosterone metabolism, you can see things like decreased libido, erectile dysfunction or impotence, problems with ejaculation, and sometimes gynecomastia, which is breast enlargement in men.
Given these different mechanisms and timelines, does combination therapy make sense? Alpha blocker for speed, 5-ARI for shrinkage.
Yes, absolutely. There's good evidence for it, especially from the MTOPS trial, the Medical Therapy of Prostatic Symptoms trial. It showed that combining an alpha blocker, like doxazosine, with a 5-ARI, like finasteride, was significantly better than either drug alone at reducing the risk of BPH progression over the long term. We're talking like a 66% reduction in progression. And even more impressively, an 81% reduction in the risk of acute urinary retention, which is a major complication we want to avoid. So, yeah, for men with moderate to severe symptoms, especially with larger prostates, combination therapy is often the way to go if monotherapy isn't cutting it. So if we were to sketch out a treatment flow, mild symptoms, AUA score 7 or less, that's usually watchful waiting.
Right, just moderate.
Moderate to severe, AUA score over 7. Then you're looking at starting pharmacotherapy. First line might be an alpha blocker for faster relief, or maybe a 5-ARI if the gland is quite large, or even daily tadalafil. If one agent isn't enough, then combination therapy is often the next step.
Okay, that clarifies the BPH approach. Now let's transition to our third topic, erectile dysfunction, or ED. Super common, affects maybe 30 million men in the US over 20, and the sources say about 80% of cases have an organic cause, often linked to chronic diseases.
That's right. While psychological factors can play a role, the vast majority have an underlying physical cause, frequently vascular problems related to conditions like diabetes, hypertension, heart disease, or atherosclerosis. Neurologic issues can also contribute. Understanding the basic physiology helps understand the drugs. An erection depends on a cascade, starting with sexual stimulation, which leads to nerve signals releasing nitric oxide, or NO, in the penis. NO then activates an enzyme that increases levels of cyclic guanosine monophosphate, CGMP. And CGMP is the key player here. It causes the smooth muscles in the arteries and the erectile tissues, the corpora cavernosa, to relax.
Relaxation means more blood flows in.
Exactly. Blood flows in, fills the corpora cavernosa, they engorge, and that compresses the veins that normally drain blood away. So more blood in, less blood out, equals an erection.
Okay, so that's the natural process. Where do the PDE5 inhibitors, like sildenafil, Viagra, or tadalafil, Cialis, fit in? What's their exact mechanism?
All right, so there's an enzyme called phosphodiesterase type 5, or PDE5. Its job is to break down CGMP. It's basically the off switch for the erection, returning things to the flaccid state. These drugs, sildenafil, vardenafil, tadalafil, avanafil, they work by inhibiting this PDE5 enzyme.
So they block the off switch.
Precisely. By blocking the breakdown of CGMP, they allow CGMP levels to stay higher for longer when NO is being released due to sexual stimulation. They enhance or reinforce that natural signal.
Ah, okay, that's the crucial nuance I was getting at earlier. They don't cause an erection directly. They rely on sexual stimulation being present first to trigger the NO release.
Absolutely critical point for patient education. They won't work without sexual arousal. They help initiate and maintain an erection once the natural process starts.
Got it. Now, there are several agents. How do they differ in terms of patient experience? Seems like timing and duration are key differentiators.
They are. Sildenafil, Viagra, and vardenafil are quite similar. Their absorption can be slowed down if taken with a high-fat meal. They typically start working within maybe 30 to 60 minutes, and their effect lasts around 4 hours or so. Generally dosed as needed, no more than once a day.
Okay, the classics. What about tadalafil?
Tadalafil Cialis is different. It also starts working around 30 minutes, but its duration of action is much longer. It can allow for intercourse for up to 36 hours after a single dose.
Wow, the weekend pill nickname makes sense then.
Exactly. Plus, its absorption isn't significantly affected by food or moderate alcohol intake, which adds flexibility. And remember, tadalafil also comes in a lower daily dose, 5 milligram, which is approved for treating BPH symptoms concurrently with ED.
And the newest one, avanafil.
Avanafil, Stendra, has a very rapid onset, potentially as fast as 15 minutes for some men. Its duration is similar to sildenafil, around 5–6 hours.
Okay, so choices depend on patient preference for spontaneity versus planning. Now, the really serious part, contraindications and warnings. This feels like the highest risk area we've discussed. What's the absolute must-know?
The absolute #1 non-negotiable contraindication is concurrent use of any form of nitrates, organic nitrates like nitroglycerin used for angina.
Why is that combo so dangerous?
Because both nitrates and PDE5 inhibitors cause vasodilation by increasing CGMP, nitrates by boosting NO production, PDE5 inhibitors by preventing CGMP breakdown. Using them together can cause a profound, potentially life-threatening drop in blood pressure.
So waiting periods are essential if someone needs nitrate.
Absolutely essential. Patients must be nitrate-free for at least 24 hours after taking sildenafil or vardenafil, and for at least 48 hours after taking tadalafil before nitrates can be safely administered. This is critical emergency information.
Okay, nitrates are the big one. What about cardiac risks in general?
You need to do a careful cardiac assessment before prescribing. These drugs are generally contraindicated in men for whom sexual activity is inadvisable due to underlying cardiovascular status. Specific contraindications include unstable angina, recent heart attack, usually within 6 months, uncontrolled high blood pressure, say over 150/40 EDI, serial level blood pressure, systolic below 90, recent stroke or significant heart failure or arrhythmias. You need cardiac stability.
Makes sense. And we touched on BPH earlier. What about combining PDE5 inhibitors with alpha blockers, since many men might need both?
That's a relative contraindication, or at least requires extreme caution. Both drug classes can lower blood pressure. Using them together increases the risk of symptomatic hypotension. If you must combine them, start both drugs at the lowest dose. For sildenafil, it should generally be separated from the alpha blocker dose by at least 4 hours. Vardenafil is actually contraindicated for use with any alpha blocker, making it a less suitable choice in that scenario. Tadalafil might be used cautiously, again starting low.
Okay, caution is key there. What about common side effects? Are they mostly related to the vasodilation?
Yes, most common side effects are due to vasodilation. Headache, facial flushing, nasal congestion, dyspepsia, or indigestion. Sildenafil is also known for sometimes causing transient visual disturbances, particularly a blue tinge to vision or increased light sensitivity.
Good to know. Phew. Okay, that covers a lot of ground. Let's do a quick recap. We really nailed down the need for that long antibiotic course in prostatitis because the drugs just don't get into the tissue easily.
Right. And for BPH, it's that two-pronged attack. Alpha blockers for quick symptom relief by relaxing muscle, and 5-ARIs for shrinking the gland size over months, especially for larger prostates.
Plus that crucial PSA monitoring point with 5-ARIs, always double the number.
Don't forget it. And for ED, the PDE5 inhibitors work by enhancing the natural response to stimulation. But the huge takeaway is the absolute contraindication with nitrates and the need for careful cardiac screening.
Absolutely. So connecting this back to your practice, knowing these nuances like the PSA adjustment or checking cardiac status before writing for a PDE5 inhibitor, that's really what ensures safe and effective care, isn't it? It's beyond just knowing the drug names.
Exactly. It's about applying the principle safely in real patients. And maybe one final thought to leave you with. Consider the psychosocial aspect here. We know men often delay seeking treatment for these conditions. There can be embarrassment or equating masculinity with sexual function. So how important does culturally sensitive patient education become? Talking openly about potential side effects like ED from 5-ARIs and stressing treatment compliance, maybe that's just as vital for success as understanding the drug's mechanism itself.
That's a really profound point to reflect on. Excellent food for thought. Thank you for joining us on this deep dive. And to our listeners, a warm thank you from the Last Minute Lecture team.